Thanks. Excellent, Catalin. Next, we're going to switch over to the surgical side, SAVR, and Dr. Ibrahim Sultan, my co-director, is going to talk to us about surgical aortic valve replacement. What does the future look like? Ibs.
Thank you again, everyone, for joining this morning. I know many of you are tubed into YouTube and live via Zoom. Feel free to put your questions and comments in the chat. We have multiple physicians moderating and can help answer those questions, and Dr. Smith will bring them to the panel. So this is a little bit of a loaded question. Does surgical aortic valve replacement have a future? Right. So here are my disclosures. And the short answer is yes, but it comes with caveats. So if you look at the aortic valve intervention universe, and we call this AVR, we don't say TAVI or TAVR or SAVR anymore, because really the goal, again, is to alleviate the patients with aortic stenosis in those particular patients. And so we've seen that there's clearly been a revolution in the management of aortic stenosis, right? And this is a nice cartoon that depicts this from back in the day from the New Yorker. What have we learned, really, over the past decade, right? We have learned that TAVI is a revolutionary technology to treat patients with aortic stenosis. It'll likely continue to be the dominant mode of treatment for degenerative trileaflet aortic stenosis. And a multidisciplinary evaluation in a valve clinic is likely to provide the most thoughtful and comprehensive treatment plan for patients with heart valve disease. And the third part is very important, and you've heard this with Dustin earlier as well. So what is the heart team, right? So the patient's primary care physician or provider, the patient's primary cardiologist, our imaging expert, interventional cardiologists, cardiac surgeon, advanced practice providers, and nurses who are with us in the clinic. But the reality is that the patient is driving most of these decisions, right? And so the patient is truly the captain of this heart team. And depending on which expert on this list they talk to, it is not uncommon that a little bit of knowledge is a dangerous thing. And so when we combine our expertise and really look at what we think is relevant comparing patient to patient, moving away from this low risk, intermediate, high risk, but really talking about life expectancy and amount of future interventions, that gives us a better framework. So what does the patient want? Which is very different than what does the physicians want, right? So patients want the least invasive option and complete relief of their symptoms. They want 0% mortality. They want 0% stroke. They don't want a pacemaker. They want to go home the same day or the next day. They want to be back to work and golfing the same week. And they want to know what is a long-term or durability plan. Some of them may not talk about it if they're not educated on it, but they want some sort of plan if their prosthesis fails. And they again, do not want any INR checks from quote-unquote rat poison. And so this lifetime management is not really a buzzword. It's thrown around, obviously, quite a bit. And we've learned this, as I'm sure Dustin pointed out, from congenital cardiologists and surgeons. So if you look at the life expectancy quite a bit ago, this is what that looked like, right? So patients who we know got to about age 65 lived for about 18 years or so. What we know is once you get 5 years past AVR, you're likely to get a survival benefit that's equivalent to the healthy population, assuming you don't have any concomitant disease. Now, this has changed over time, and this continues to increase, particularly in women. So what is the patient with aortic stenosis here, whether they get direct mailing from one of the companies in their mail or what their PCP tells them or what they read in the news about Mick Jagger, which is, well, first valve, get a bioprosthetic cow or pig valve. There's all these new technologies, right? It's going to last about 20 years, and then you go in and you go get a valve through the groin, right? What that patient should really know is that the time to failure is really about 7 years median. It's not 13 years. It was 13 years when we didn't monitor these patients as aggressively with echocardiograms. It was 13 years when a 90-year-old, after getting a surgical AVR, was not referred for any intervention because valve-in-valve therapies didn't exist. That's when it was 13 years. We know, based on valve-in-valve registry data, it's about 7 years when these start failing. The second valve-in-valve TAVI, which is usually a TAVI, is usually in the, let's say, late 60s or 70s. And so what do you do when it's time for your third valve, right? And again, there's a variety of leaflet modification techniques that may help, but again, it's a little bit pie in the sky and very much restricted to certain centers. Or worse, and this is what you see perhaps on either coast or big cities. Well, get your TAVR when you're about 6 years old. It'll give you about 15, 20 years, and then get another valve-in-valve, and then get another valve-in-valve, and then get another valve-in-valve. We also know that if we explant these valves, the mortality, morbidity, stroke risk is significantly higher than just a simple redo surgical AVR. This may change with experience, but we do know that anatomically it's a much more challenging process. And again, with each valve and valve, this is a nesting doll concept. So again, not just a buzzword, right? So it's an outstanding strategy, valve and valve TAVI, starting with a bioprosthetic valve for patients with structural valve degeneration. But it all depends on the anatomy and the first valve the patient has. The most common bioprosthetic surgical valve implanted in this country is a 21 millimeter tissue valve. We know this. If you ask a surgeon, they will tell you their average is about 25 or 27. We also know that that is false. Based on registry data, it's a 21 millimeter valve. In fact, majority of the valve, nearly 70% of the valves that are placed are about 21 or 23 millimeter valves. This is an example of a patient who was presented with patient prosthesis mismatch after a 19 millimeter valve, had a mitral valve repair, LVOT expansion, and a Manugian enlargement to place an appropriate size valve in. So again, index valve size is key, right? The other concept that comes to this is it depends on what the pathology is. Bicuspid patients are very different than patients who have trileaflet disease. The anatomy is different, the pathology is different, and most of these patients in trials were all self-selected based on CT anatomy. Type 0, very different than a type 1. Calcified raphe, different than a non-calcified raphe. So again, I think the hammer nail concept doesn't apply to all bicuspids, which are typically young patient or low-risk patients. The way we implant these valves matter. If you use foreign body and materials and pledgets in the LVOT, that is going to give you a higher gradient when you get a valve and valve TAVI. And so it's important to think about all these things. The approach and strategy matters. Patient care about the size of the incision, how soon they can get back to work, and what that involves. And again, when it's isolated, a sternal serring approach is very much appropriate through a small incision, allows patients to drive sooner, get home quicker, et cetera, et cetera. And importantly, valve choice matters. In a patient with a BSA of approximately 1.9, even a 19 millimeter mechanical valve, not something we recommend, it may be appropriate, or a 21 millimeter valve. For that exact patient, you need a 25 millimeter surgical bioprosthetic valve. So again, it's important to understand how hemodynamics and EOAs matter between mechanical and tissue. And so this is kind of an algorithm that we think about, well, and go down the pathway depending on age and risk where they are. We also know that there is no perfect option. They all have their advantages and disadvantages. And the thing that I would beware of is really the part at the bottom, which is the trendy options, where all sorts of variety of different valves come in. These patients are coming to us when they're low risk and they're young, and they want durability. They're not coming to us for a fancy option. And I think it's important to consider this and use long-term data that we have before we go into it. And it's important to be aware of the hype, right? Every new valve talks about, it looks great for about 5 to 7 years, and you see this in all the ads, 100% freedom from SVD, from symptom relief and reoperation. But we know that these valves start to fail at about 7 or 9 to 10 years. And these are some examples of valves that have looked perfect in the midterm and started failing relatively quickly. And again, understanding these data is important to make these decisions. So again, going back to what the patient wants, right? And these decisions, depending on their risk category, and again, this is no longer for us defined by STS risk standards, but more based on life expectancy and how these patients are going to live. And so high risk and intermediate risk, even though we don't discuss this, we know that mortality and morbidity is likely the same at 5 years. This is what we know from historic data. But despite that, we would favor TAVI for these patients, particularly virtually everyone over the age of 80. In low risk, or what I would call younger patients, we know that TAVR equivalent to SAVR at 3 years, and I put giant asterisk marks there because we only know this for self-expanding valves. This is not the case for balloon-expanding valve. There's no data to prove that. So when we have these discussions with patients, it's important to note. Concomitant left main or proximal LAD disease, very simple, aortopathy, prior bioprosthesis, bicuspid aortic valve, which deserves an hour-long talk by itself. And so when we look at future of SAVR, it is very likely that it may be, apart from what we would do treating low-risk or younger patients, perhaps fighting structural valve degeneration down the line. Great. Thank you again, and excited about the rest of the day. Appreciate it.